Hello, I'm Manoj Karmakar. In this next video, Dr. Kris Vermeylen from Turnhout in Belgium is going to be discussing with us the Supra-inguinal Fascia Iliaca plain block and its role for perioperative analgesia during total hip replacement. If you're enjoying our videos, do remember to like and share these videos with your friends. Also, do remember to subscribe so that you can get regular notifications of any future uploads. Now enjoy the upcoming video.
So Professor Karmakar asked me to say something about fascia iliaca compartment block, and try to just, yeah, okay. I have no conflicts of interest. Actually, I do have one conflict of interest. The fact that I did my PhD on the fascia iliaca compartment might benefit a little bit in my talk, just for making some promotion for the fascia iliaca compartment block, of course. But other than that, I don't have anything special that I have to announce. So who am I? I'm Kris Vermeylen. I'm coming from Belgium. For those who don't know where Belgium is in Europe, and it's between the Netherlands, England, France, and Germany somewhere. And I'm living in Antwerp. I'm working in Turnhout, which is close by to Antwerp. And Antwerp is known for its big port, one of the biggest ports in the world. But we are probably more known for our paintings, our beer, and our chocolate. And actually, the painting, the picture on the left here is the place where we are now, because we are actually currently holding our refresher bara, like this is the Belgian association. We're holding this refresher course on regional anesthesia as we speak. So I had to divide my time a little bit, but I'm very happy to be here, of course. If we want to talk about hip surgery, we know that hip surgery is much more than just the surgery itself. We're talking about orthogeriatrics, we're talking about a high incidence of surgery, we're talking about ERS protocols, prospect guidelines, a lot of therapeutic possibilities, cognitive dysfunction, delirium, and so on and so on. So me talking about therapeutic possibilities and then talking about the fascia iliaca alone is only just one part of the whole subject of hip surgery, of course. We have seen that a variety of regional anesthesia techniques have been shown to improve analgesia after or for hip surgery. And of course, the most important thing of regional anesthesia is the knowledge of the nerve corresponding to the surgical site. So we have a lot of nice articles for the hip innervation, and I think that the following two speakers also are going to speak some about these anatomy things, so I will not go into that too much, but we know in general that we have an anterior innervation and that we have a posterior innervation, and the anterior is of course the femoral and the obturator nerve, and the posterior is the sciatic and some smaller nerves. The main players of the regional anesthesia techniques are the posterior approaches of the lumbar plexus and the anterior approaches. And the anterior approaches are the much more favored approaches. A long time, a lot of people did some femoral nerve blocks for hip surgery, because it was also in the prospect guidelines, which are the procedure-specific guidelines for postoperative analgesia in some kind of field. And that was the prospect guidelines in 2010 still had the femoral nerve block in it. Now the new guidelines also included the fascia iliaca compartment block. The new guidelines were published last year, and the fascia iliaca compartment is actually an old block which got some new interest since the superior supra-inguinal approach was published and well known to a lot of people. Then we have the really new pen block, and I'm sure that because I'm also a very big fan of a pen block, some people think that I don't like the pen block because it's a little bit contrast to the fascia iliaca, but that's not true. And I think that if the pen block was described a little bit earlier, it might have also been included in the new prospect guidelines. So the anterior is the approach which has been used the most, I think. We also have the posterior approaches. The psoas compartment block is the more classic one. It was still in the prospect guidelines in 2010, but it got out in 2019. For me personally, during my training, I never did actually a lot of psoas compartment blocks because I was taught that it's a dangerous block, that you can have epidural spread, but you can have a lot of also infections and bleedings and things like that. So I was not trained very well in the psoas compartment block. And then you have some new kids on the block, the QL and the ESP. We already talked a little bit about the ESP in the session before this. I think those blocks are still, they still have to prove themselves. I think, I don't know, I don't want to go into that too much because I didn't see very big studies yet. So, and that will probably be subject of another talk by somebody else, of course. So which technique should we choose? And if I look at the prospect guidelines for the hips, and I already told you that the new guidelines were published last year, that you see that the single-shot fascia iliaca compartment block or even local infiltration is one of the overall recommendations. And again, I think if we would have been a little bit earlier with the PEG block, PEG block would also be included in this. So maybe for the next guidelines, who knows, we can do that as well. But I was asked to, a long introduction, I was asked to say something about the fascia iliaca compartment block. And let me say first something about the history. The history, it's already a long history. And it's actually the first time it was described was by Professor Winnie. And at that time, it was a blind technique. It was an infra-inguinal technique. And over the years evolved to an ultrasound-guided approach, but still transfers approach. And in 2011, it was Hubbard who described the supra-inguinal approach and the longitudinal approach. And I was very intrigued by this approach, and that's why I started my PhD doing using this approach for my studies. Now, if we talk about the fascia iliaca compartment, it's very important to define what the fascia iliaca compartment actually is, because if you know what the compartment is, you can understand it much easier. The fascia iliaca compartment is nothing more than like a virtual tunnel, which is formed on the posterior side by the psoas and the iliacus muscle, on the anterior side by the fascia iliaca, without being attached to the muscles. And in between, you have the nerves, you have the vessels and things like that. So you can imagine if you put a local anesthetic in this virtual tunnel, it is important where you put this local anesthetic. If you put it here, or if you put it here, and it can make a very big difference because of the anatomic structures. And it is clear as well that if it's like a very big compartment, the volume that you will put in it is very important too. So for my PhD, we did a good anatomy study. We looked at a lot of cross sections, high resolution images. And if you wanted to know which nerves you wanted to block in the fascia iliaca compartment, we came to across, of course, the femoral nerve, the lateral femoral cutaneous nerve, and the obturator nerve. Now, I know that the obturator nerve is a big discussion in the fascia iliaca compartment, and I will talk about that later. But what we saw and what other people also described is that if you can put local anesthetic high enough in the fascia iliaca compartment, and that would mean above the level of L5 as 1, but because that is the level where the obturator nerve pierces the fascia iliaca compartment, and then you can't reach it anymore. So you can imagine if you put only local anesthetic here, it will not work, or it will work, but it will not reach the obturator nerve. Now, what about the history of those nerve anatomy? Actually, nothing is new of this history, because these nerves, like the femoral nerve, obturator nerve, and even the lower and the higher and the accessory obturator was already described in 1948. So that's not new. There were a lot of anatomy studies, and again, I hope that the next two speakers are going to speak about those also. A lot of anatomy studies and a lot of sensory innervation studies, and they all came across the fact that it's just very difficult innervation, and it's very difficult to have a good summary of how the innervation is done. So again, new studies also looked at these nerves and saw that the femoral high, femoral low, obturator high, obturator low nerves were described. Also other nerves were described. But the new thing about it is that they were looking now at the mechanoreceptors and sensory fibers as well for determining where the most local anesthetic should go. In other words, the place where the most receptors are is the place where you could find you should get your local anesthetic. And in these studies showed that for the capsule and for the labrum, the most receptors are on the anterior side. A long story to conclude that we should get a local anesthetic on the anterior side of the hip, and therefore the anterior approaches are much more favorable. Now, if we look at the fact if the fascia iliac compartment is a good alternative for a postoperative analgesia, we have to look at some studies. And this is one of the studies we did, and we saw that we had a reduce of morphine consumption, not only after 24 hours, but also 48 hours, with half. So we could conclude that there was a big reduction in morphine consumption. So the effectiveness of the block would be okay. Also, not only for the morphine consumption, but also the pain scores were much lower in the first hours and 24 hours postoperatively. So we could say that we are talking about an effective block. But as I mentioned already before, it is important to have the right volume and the right approach, of course. So what we looked at in another study is that if we were looking at the classical approach, which is the supra-inguinal approach, the infra-inguinal approach, and we compared it to our supra-inguinal approach, then we saw that it is important to get the local anesthetic as proximal as possible. So putting the local anesthetic underneath the ligament inguinal, then you will not have a good spread. And this is what we saw when we injected 40 mL of local anesthetic, and we compared the supra-inguinal and the infra-inguinal approach. Not only did the local anesthetic reach much higher, also the volume was much higher when in the higher compartments. So the effectiveness of the supra-inguinal approach is much better than the infra-inguinal approach, and that's why we want to suggest that the supra-inguinal is superior. We have also the influence of injection volume. Of course, we know that it is, I already explained you that we have a long virtual tunnel, so it's important to get enough local anesthetic in this tunnel. And we did another study for that, and we saw a study that we would need at least 40 mL to get the local anesthetic all the way to the different nerves. This was a cadaver research, and I also know that a lot of people always doubt a little bit cadaver research, because then it's we should do it on like real patients. But also studies afterwards showed that, and I will come to that later. Studies also showed that you have to have a high volume. So high volume for some people is dangerous for toxicity, but we come to that later as well. So for approach and for volume, I think we should go for a supra-inguinal approach and at least 40 mL of local anesthetic. Now, something, it's not that new anymore, but it's thing that not have been researched a lot, is the fact that you also should take into account the biodynamics. And the biodynamics is, first of all, for those who read this article, this is a very good article, back to the basic of the fascia plane box. And to understand the biodynamics, it's important that you can look at these as well. Now, what we wanted to look at is the fact that you have intraoperative movement of the leg. So we asked a surgeon to mimic a surgery of hip. And what we did, so one side we didn't, at one side we didn't move the patient, and the other side we did some passive movements, and then we put the patient on the MRI, and actually it was not the patient, it was myself, We saw that with passive mobilization of the leg, the local anesthetic got much higher, and the volume also got much more intense in the upper region. So this is only a little pilot study, but it proved that perioperative movement, and especially in orthopedic surgery, where there are a lot of movement and a lot of traction and things like that, are important for the spread of the local anesthetic. And there aren't any studies looking at that at this moment. So I think that maybe for the fascia iliaca, it is very important to look at the fact that during the operation, the local anesthetic might go more proximal, and maybe that's the reason why the obturator nerve is blocked anyway. So this is, I think, a base for a lot of more studies, and I think it's very interesting and very new, actually. Now, like for everything, you always have the believers and you have the non-believers, like you have the people who are getting a vaccination and the anti-vaxxers. And I think that's important too, because you have to have a good discussion. And the ongoing discussions for the fascia iliaca compartment block at this time is, there are four main things. The role of the obturator nerve, I already told you something about it. Second, we have the fact that we are using a large volume. We have the fact of the motor block, and we have also block failure, because none of us is the most perfect guy in performing block. So once in a while, we'll have block failure as well. Let us start with the obturator nerve. Some people are determined to prove that the obturator nerve is not blocked with the fascia iliaca compartment. It has been a very interesting discussion, and we have been talking about that very much. But on the other side, you always have the pros and the cons, and we also did a lot of anatomy research, and we did find that we could block the obturator nerve. But I think it's important to have the discussion going, because then we keep on thinking about where the nerves are and if we can reach them, of course, and what the difference is with cadaver research, what clinical implications are important, and also the effect, of course. The obturator nerve might not even be so important for the hip surgery, because in this study you see that they conclude that the obturator nerve does not have an effect on analgesic benefits in the hip surgery. So maybe all the discussion about the obturator nerve is all obsolete. Second thing is the large volume. I know we have to use a lot of volume, and that's at least 40 mL. But if you use low concentrations, and we did some plasma concentration studies also, we saw that we didn't reach any toxic levels. We didn't reach any neurological or cardiac symptoms whatsoever. So we can conclude that it's quite safe to use 40 mL. And we did, in this study, we used 40 mL of 0.5%, but in fact, in clinical basis, we're using only 0.25. So we could use even more local anesthetic if we want. In this study, they looked at it was also a cadaver study, and they looked at the minimum effective volume, and they came across the fact that they should use, or that volume of 26 mL should be injected to reach the obturator nerve. But if you use 26 mL, 62 mL, this is like an ocean of local anesthetic around the obturator nerve. So maybe 40 or 50 will be enough too, because we have the clinical effect. Again, you will always have the believers and the non-believers. And into a letter to the article of this cadaver research, somebody said that it was an artificial passage of the local anesthetic and it could not be reached. Well, there is also clinical studies. There are also clinical studies proving that the obturator nerve is reached. So another thing is you have to use, and another thing in the letters, they said, it was not reached by 30-40 mL. No, of course, because you need 60 mL. And then they say, but if you use more than 40 mL, it can be toxic. On the other hand, same people have been studying, or have been publishing studies using 60 mL. So you always have the pros and the cons. One thing which is clear with the fascia iliaca is that you have a motor block. You have a motor block, and you would rather have not a motor block, of course, because the ideal regional anesthesia technique is easy to perform. It's good, a good analgesia, a low concentration of local anesthetic, so you don't have too much toxicity, or a long-lasting action, and no motor block, of course. And the pen block is a solution for this motor block, I think. And for those who are not familiar with these movies, they are very nice. They're all produced by Jeff Katzen, and he has a Blocktober. And if you have the time, if you want to look at them, they're really nice movies. And Jeff made a movie of every block. So if you want to look at it, and maybe you already did, but it's very good for learning all those different blocks. What he showed also is that, and that will explain, of course, the motor block, is that the pain block will work directly on the hip joint as well, and I'm definitely that Dr. Peng will talk about that much more. Instead of the fascia iliaca, it's much more proximal, so it's normal that you have more motor block, of course. And this was proven in this comparative study, that you could see that there was a quadriceps motor block at 3 hours. For the pain block, it was only 45%, like for the fascia iliaca, which was 90%. At 6 hours for the fascia iliaca, we're still at 85%, and it was only 25% by the pain. So you do have a little bit of motor block by the pain block, but I think that's much more, individual differences, because I think in the trained hand, you don't even probably will not have that much of motor block. And I think that Dr. Peng will talk about that more. In the same study, they also showed that the postoperative pain scores are the same, that the opioid consumption is not different, ability to perform physiotherapy. And we know that physiotherapy is important for, if you start physiotherapy early the first day of breathing for 24 hours, then you can reduce hospital stay, of course. No significant difference between opioid-related side effects or the length of hospital stay. So I think pain block is a very good alternative if you are a little bit scared of the motor block. Motor block is something which is, I think, very difficult to measure, because most of the time it's subjective scales. It can be influenced by pain, or it's an antalgic-induced motor block, or the influence of bandages or things like that. So I think it's very difficult to have a good idea what the motor block actually is and how it is performed to, or how it is studied. So that's why we're doing a new study now, and instead of just asking subjectual scales, we are going to use like a dynamic manometer and just measure how much Newton is lost by performing blocks. And then we have the last one. The last one is block failure. And we all think we don't have any failures. And if you look at the efficiency of different studies, the efficiency is very good. So, but then I want to ask you all, how many of you ask for residual pain? If you put in a block, do you still ask the patient if he has pain, and where the pain exactly is situated? And how do you test these hip blocks? Because I want to present you this case. It was a male, 85 years old, and he slipped on the ice. He broke his hip. He got on the ICU, he got a regional technique, and in this case it was a pain block. And when I asked him how the pain was doing, he said, my pain in the front of my hip is much better, but now I have pain at the posterior part. And I didn't say posterior part, but he said at my buttocks, I have a lot of pain at my buttocks now. So the anterior pain is completely gone. And if we are looking at the reasons or the where the pain is coming from, we can have a lot of other reasons, not only for the hip, but you can also have hematoma of muscles and things like that. So sometimes you see that the pain or the pain sensation can move. And in our case, we saw that the pain moved from the anterior side to the buttocks. And if we look at the innervation of the buttock, we see that it's actually more the sacral plexus. So what I want to ask you, which nerve should we focus on? Because not every hip fractured patient is operated at the same day. Some have anticoagulants or just for the program, they have to wait for the next day. So what do? Do we just give them an anterior block, and if they have some residual posterior pain, we just give them, I don't know, some paracetamol or what? Or can we combine it with something posteriorly? Therefore, should we focus more on some segmental innervation, or should we focus on more the dermatomes in looking at the approach of the regional anesthesia technique? So this explanation is that you might not have block failure when the pain is moving from the anterior side to the posterior side. And therefore, we wanted to look at some posterior innervation a little bit more. And excuse me, I am not going to into any details, but I already told you that while I was not very fond of the classical posterior approaches because I didn't learn them very well and because I'm afraid of the adverse effects. But going back to the drawing board, we try to find a new posterior ingluteal approach, and I hope to tell you about that more in future. But what we did do, and this is some MRI studies already, is you see that putting in the local anesthetic on the posterior side, you could reach the sacral plexus. And this is just going from proximal down, and this is the anterior posterior side. So I will talk about that later because it's not really the fascia iliac compartment block, but it is important if you want to evaluate your block failure of, for instance, the fascia iliaca or the pain block. So I think it's very important not only to speak about the blocks themselves, like fascia iliaca, pain block, but to speak about anterior and posterior compartments. And I think we have some work to do, and like we already have the Delphi consensus about the truncal fascia plane. I think we have to have those of the hip region and also maybe the brachial plexus. And that's a work in progress for the future. We did a little pilot study. We did a few patients already, and coming in with a fracture on the ER, we performed a pain block, and they had a big reduction, a significant reduction in pain after the pain block. But we also combined it with our posterior approach, and we saw that the pain was even much less. So I think that is something we have to look in the near future. And the happy coincidence is that Professor Peng is also busy with some posterior approaches, and not the next talk, but the talk afterwards, they will explain that for us. So that's very interesting, and I hope in future we might get together to somehow do a study together on these posterior approaches. But for now, I'm still a very big fan of the fascia iliaca. Of course, I'm a fan of the Peng block, but Professor Peng will talk about that later. I think it's important not to focus too much on the nerve technique itself, but we should focus more on the scenarios, on the compartment, the anterior and posterior compartments. And we know that pain is not only the bone, it's not only the fascia, but it's the skin, the muscle, the fascia, and the bone. So I think our postoperative regimen should be involving all those different things. So to conclude, I'm very happy with my fascia iliaca compartment block. And I'm very happy to see that it's also part of the prospect guidelines. Once I don't know if you ever saw this meeting of the ERA UK, but the funny thing is that they all asked these famous guys what they wanted to have for their hip. If they had a hip fracture, and they all said something different. So there is not one way. I think it's very important to do a technique which you have been doing already quite a long time, which is a good technique. The optimal anesthetic approach of the hip surgery is still a subject of debate. And we know that adequate analgesia is important and essential for a good recovery. And we have a variety which all have been showing to an improved analgesia. And I think the quality of the perform block is much more important than the block itself. For me, I still love my fascia iliaca compartment block, of course. And on that note, I think, that concludes my talk, I think.